Dr. Biswas? Dr. Biswas?
Yes, yes.
We can start.
Can I start off?
Yeah.
Good evening, everyone. Thank you very much for joining this evening. As you all know that we are conducting this series of 3 webinars. We are on the third and the last of the series on cervical cancer. This is an initiative to build conversations around cervical cancer and HPV vaccination in line with the call given by WHO for eliminating cervical cancer. This whole exercise has been a year-long exercise for WHO and us together so that we talk more and more across platforms. So thank you everyone for joining today. And on behalf of ASSOCHAM, we have someone very special to welcome us, Dr. Blossom Kocher. Dr. Blossom Kocher is a co-chair, ASSOCHAM Empowerment Council and chairperson of Aroma Magic. She is that magical personality synonymous with aromatherapy in India. 35 years went into creating unique aromatherapy-based beauty products and building that into the most trusted brand, that is Aroma Magic. She's a double doctorate in aromatherapy, a teacher, and chairperson of Blossom Kocher Group of Companies, along with the Blossom Kocher College of Creative Arts and Design. Bestowed with many awards, she is indeed an inspiration to many around the world. Dr. Kocher is currently working with the Delhi government for the entrepreneurship program. Dr. Kocher. Ma'am, I think you need to unmute yourself.
I'm unmuting.
Yes.
Oh, that's fine.
Yeah. Yes, perfect.
Unmute. Okay. Yeah, good evening. Good evening and a very warm welcome on behalf of the Associated Chamber of Commerce and Industry of India to all our distinguished panelists who have gathered to share their thoughts on promoting HPV vaccine to empower preventive healthcare for women. The third session of this series, which with ASSOCHAM, is organizing with CFI as a knowledge partner, will be focusing on engaging the community for HPV vaccination. The high levels of HPV vaccination acceptance seen so far most likely are due to the extensive educational work done in communities prior to vaccine introduction. In any vaccination program, education and engagement of the community are the main keys to remove the economical, psychological, and cultural resistance. Our goal of primary healthcare is for communities to own and demand the health program or intervention, but this can take time. Within communities, there will be many voices, some actively supportive, others passively accepting, and some actively opposed. For engaging the community on a large scale, HPV vaccine program must include effective education and mobilization of key stakeholders, including not only parents, health practitioners, and girls, but also community leaders, religious leaders, teachers, and journalists. Today, we have a great panel to discuss this important subject. With this, I would like to hand over to Mrs. Satupa. I hope I pronounced that name correct.
Yes,
It's such a lovely name. Looking forward to a fruitful discussion. Thank you.
Thank you very much, ma'am. Thank you indeed. And you put it right that, everybody has to talk about it and everybody has to know about it because, cervical cancer doesn't get talked as much in India as the other cancers. So I think that's the reason why we need to talk more and more. And as I said, keeping in line with WHO's call for elimination, all of us have, I think, equal responsibility, and all the more in India, which has a very high incidence of cervical cancer and a number of deaths that happen every year, despite it being a preventable cancer. Well, cervical cancer is being talked about in the past 2 webinars. we found that it has a vaccine that works, it's safe and effective, it's available, but it still needs to go a long way in India. So in order to understand more on how we all can be a part of this, we had organized this webinar on the subject, as Dr. Kocher said, is engaging the community. I think that is most important, but there are ways to do that. And we have the best experts here who can tell us what could be the best way at an individual level and at a community level. There are a lot of groups who are working, of course, and we want to share or learn from them and share with all of you the experiences that they have had. But before I start, the first person that I am thinking of in the panel of speakers, I must introduce all the other speakers before I take the questions. Padma Bhushan Professor Nirmal Kumar Ganguly, former Director General of the Indian Council of Medical Research, ICMR, Government of India. Professor Ganguly is a distinguished biotechnology research professor and a visionary providing leadership to health sciences in India. He is an MBBS from Calcutta, an MD from PGI Chandigarh, who has been conferred 6 Doctorate of Science DSc degrees. Professor Ganguly is a fellow of all the Indian Science Academies and that of the Imperial College London, Royal College of Pathologists, Tropical School London, Academy of Cardiovascular Sciences Canada, Third World Academy of Sciences Italy, to name just a few. He continues to provide leadership to many scientific institutions across the country and has been the past president of many societies on microbiology, parasitology, immunology, diarrheal diseases, and nutrition. He has been conferred several prestigious awards, including 7 international and more than 100 national awards, 113 to be precise. He has been honored with the prestigious Padma Bhushan Award by the President of India in 2008 in the field of medicine. Professor Ganguly has published more than 775 research papers and has supervised 130 PhD theses. Thank you very much, sir, for being with us today. We have a wonderful panel of speakers today who have, I think, the best knowledge in working across the world and in India, who can share how we can engage with the community. And to lead that, we have Dr. Cherian Varghese, the cross-cutting leader for NCDs and special initiatives, including Cervical Cancer Elimination Initiative of the World Health Organization in Geneva. Dr. Varghese is responsible for the overall guidance and program management related to NCDs, multi-sectoral plan development and research. He has been with WHO since 2001 at the country, regional, and global levels, and from 2015 he has been in WHO Geneva as coordinator for NCD management and established the NCD department in 2019. Prior to this, he has worked in clinical oncology and epidemiology in India and cancer research in Leeds, UK. Dr. Varghese holds a medical degree with postgraduate qualification in radiation oncology with training in health and hospital management. He holds an MPhil from Cambridge, UK, and PhD in epidemiology from Tampere, Finland. He has more than 90 publications in the field of NCDs in peer-reviewed national and international journals. Thank you, Dr. Varghese. Dr. Hema Divakar, Medical Director of Divakar Specialty Hospital in Bangalore and former President of FOGSI. An accomplished medical professional, Dr. Divakar is a senior consultant and obstetrician and gynecologist with over 3 decades of experience and expertise in women's healthcare in India. She is an advocate in delivering quality healthcare and capacity building, along with being an influencer for socio-legal issues related to women's health in India. Dr. Divakar has exhibited exemplary leadership in a professional capacity as president of FOGSI, the Federation of Obstetric and Gynecological Societies of India, in 2013, and she continues to be active in various committees of FIGO, the International Federation of Gynecology and Obstetrics. Her work has been widely recognized with coveted awards from FIGO, Icons of Healthcare Award from Singapore, Global Asian of the Year Award in 2018, Lifetime Achievement Award from the Diabetes and Pregnancy Study Group in India. Thank you. Thank you, Dr. Divakar. Dr. Sharmila Pimple, Professor at the Department of Preventive Oncology at Tata Memorial Center in Mumbai. Dr. Pimple is an MD in Preventive and Social Medicine from Grant Medical College in Mumbai with specialization in cancer prevention from National Institutes of Health, USA. Her focus has been on both clinical and research work in cancer control, prevention, screening, investigating early detection methods, and integration of the evidence-based interventions into public health programs. She has evaluated various low-cost technologies of cervical and oral cancer screening, along with leading research trials for safety and efficacy of HPV vaccines. She has been an integral part of the teams developing national guidelines and protocols for cancer control in India. Her research work has been highly recognized nationally and internationally. As a dynamic public health leader, she continues to represent India in professional international platforms, sharing her insights on cancer control. Dr. Pimple has 49 publications in peer-reviewed national and international journals. Thank you, Sharmila. Dr. Rohit Gatule, the Medical Director of MSD India. Dr. Gatule is an MBBS from Grant Medical College, Mumbai, and an MD in pharmacology from the prestigious Banaras Hindu University. He began his corporate career almost a decade ago and has worked in Eisai, Roche, and Novartis. While at Novartis, he led the oncology medical team in cross-functional initiatives across various cancers, including breast cancer, lung cancer, melanoma, and immuno-oncology. Currently, Dr. Gatule serves as the primary country-level contact for medical affairs and drives the strategy for India. He is a part of the India leadership team responsible for creating and maintaining a high-performing and highly compliant team across all product portfolios of the organization. Thank you, everyone, for finding time today, for being here and helping us understand how to engage with the community at various levels. Each one of you come with your expertise, and we are absolutely fortunate to have all of you together at the same time. Thank you so much. As we start off the discussion, I would like to have an overview from Professor Ganguly that, we all know that it is possible to prevent cervical cancer. There are the ways of screening, there's vaccination, there's ways to treat. But how relevant do you think it is for India to prevent cervical cancer, sir?
Thank you very much, Sutapa, for this opportunity, and Dr. Blossom and all the organizers. Actually, cervical cancer is a misery, and more poorer you are, more miserable you are if you have this disease. What I have tried to do is get the death counting and active surgical cases. That is a better counting, because more of the others are actually assumptions. So if we take WHO figures, around 5,70,000 women around the world are suffering from this. But next thing is very startling. Around 3,20,000 women are dying. And when you say the similar India figure, it is around 1,22,844 cases, and 60,000 of them are dying. So majority of the cases, they are coming very late. According to Tata Memorial Center, Dr. Sharmila is here, the majority of cases come at third and fourth stages. They need not do that. It is eminently preventable and can be reduced by public health measures like circumcision. Whether you are Hindu or Muslim or Jew or whatever it is, circumcision is a healthy practice. India, you know that we have a problem with circumcision. The multiparicity, having good reproductive health, etc. There are about 6 or 7 major public health measures which brings it down. And when I was talking with Dr. Badwe and Dr. Indranil Mitra, both of them said that in Maharashtra, the educated Maharashtra and in the suburban Maharashtra, it is automatically coming down without even vaccination. My journey in this started with a case on us by which was filed by the women's group in India. Dr. Usha Luthra, who was the NCD chief, started an early diagnosis through Pap Smear. And so some of the ladies who underwent that, they got cervical cancer, and because they didn't followed up, they were not followed up, and they filed a case that we should not have had it. We participated in it and we should have diagnosed early. So the justice told us that what did you do? We said that we gave them counseling, we gave them a card in which if they come to All India Institute, they will be seen early. They were asked to come 3 months, every 3 months for a follow-up. But so it's not our fault. He said, no, it is your fault. Whatever you might have told them, they didn't understand it. Why they will not come? Why they will have cancer? So it started with the so Pap Smear was a revolutionary thing, but it really didn't help because you could not go very interior to really do this. So the acetate smear and the visualizer came up, and you could really do it and screen large number of women and in a very wide variety of settings and get a very early one. And Chinese even carried a cryo can in a very rural setting, and if it was very early, they could really uh, really treat it right at the village setting. So they were very successful in this, and this could have been done anywhere. But the revolution came, recent revolution came, when a small colposcope, otherwise colposcopes were available, and the visualizer, of course, was available widely, but colposcopes were available at the only centers. So this was a small colposcope which was just this size, and this could be inserted by a nurse or even a high school or 8th class passed girl. Dr. Nirja Vatla from All India Institute actually trained the Bangladesh girls to do this, and you could visualize this lesson, and it could be transmitted to caregivers, and caregivers then gave a diagnosis. And if you needed a surgical maneuver, you could then be taken to there. I did this in a setting known as Aragonda. Dr. Pratap Reddy actually funded it. It is his birthplace. So it was done in the entire community, and we did it in another 15 centers in Chennai. And it was very, very successful. This particular device was made by Philips, India, and in the Ludhiana plant. And about in the Apollo Chennai Cancer Center, the caregivers actually provided the inputs. And we had only 7 cases in Aragonda which needed to be operated. We took them and operated them and brought them back. And now we have in the Chittoor, we have a medical college which is run by Apollo Group. They are covering a very large area at Mandala. So it could be done. And communities are also coming up and doing it. So coming to the vaccination story, this is a very fascinating story. And the main architect for all of this, I will give the credit to Dr. Zurhausen. Dr. Zurhausen created a linked papilloma with the cervical cancer. Now papilloma is also linked with the oral cancer. And 16 and 18 were found to be prominent ones, but in India there are other strains which are 31, 49. We have 4 strains which are for 80% of the cancers. So he created a direct relationship, and he created a diagnostic. Previously, there was only one diagnostic test which was FDA approved, which was a very important part, because if you could really say that there was no papilloma thing of colonization after a certain period, you could really rest as easy and could avoid so many other things and so many follow-ups and other issues. There is now a urine test also available, which is totally non-invasive, easily doable. There is certain percentage of error over there, which is not allowed, but this is also available. So Dr. Zurhausen's path-breaking work ultimately led to these 2 major vaccines. One was Gardasil and other was Cervarix. Glaxo guys didn't have a neutralization assay, but the Merck guide has had a neutralization assay, and this was, however, the antibodies cut across the system, and in the initial stages, only colonization was taken as endpoint, which was easy, which was a very easy endpoint. Later on, of course, now there are a lot of follow-up studies in which you know that how much does it protect. It protects around 70%, a little less. And the Mark 1 also protects against anal cancer and warts, but they are very small number in India. Public health-wise are not a concern. However, a multivalent one is needed, and both are L1. Both are L1 antigen, but you could use, there are therapeutic vaccines which are also under different kinds of trials, and these therapeutic vaccines could also be used as and when they get approved.
Very encouraging.
So few more points I will like to say.
Yes,
I had a very bad journey in this vaccine field, and then very good successful journey after that. My bad journey happened that when I was ICMR chief, I got 14 meetings with the health ministry. At that time, Mr. Prasada Rao was the health secretary. And it was very good that ultimately I could get the community to agree that we need cervical cancer vaccine in India. And ICMR and the Merck, they signed and they started a trial. But after that, I left the place, and I had said that we create a, like I did HIV, 2 HIV vaccine trials in India. Nobody actually bothered me. I went to Mr. Vajpayee, presented it. We went to Mr. Abdul Kalam, presented the results, brought in all the activists and journalists and everyone, and there was a committee which said everyone, right from parliamentarians to everyone were put in loop. Something happened in between when I had left, and then all hell broke loose because in one of the tribal areas, 4 girls died. One committed suicide, one was pesticide, one 14 days, which was not related. None of them were related.
Those were past, I think.
However, there were a few lapses happened because ethics committees are important. And in the tribal area, the ethics committees are different. You have to go to tribal committees and other kinds of permission. So in the Indian Council of Medical Research, there was a temporary stoppage which was put up there. However, this was removed in one very elegant setting when I was a part of chair of the Rajiv Gandhi Center in Kerala, Trivandrum. I had a director there who Radha Pillai. Radha Pillai did this in 6 different states, found out fantastic results, and brought had a fantastic results for the 2 doses. So you could really save money. And at the moment, 1 dose study is also in the progress. So and in between, Sutapa and the group did a meeting in Sikkim, and I remember that very vividly. Bhutan used it. Government of Bhutan used it, and government of Bhutan is still using it. In Sikkim, they did a very good KAP studies as well as training and introduction, but got bogged down because a clear-cut funding was not available. Then when I am a part of the global health strategy also, so global health strategies did a meeting here, brought in the first ladies of 7 African states in India. And then Indian government, when one by one they said that we are introducing, Indian government agreed to introduce it. And there are two states which came up. One was Vinny Mahajan, Chief Secretary of the Punjab, and the other one was Mr. Padmanabhan. He was a very big pioneer in Tamil Nadu. Tamil Nadu government also agreed. So the government, the different government, state governments took up initiatives, and it was it is a possibility now for an all India introduction. But as it was stated, we need communication and advocacy. We need to
Yes.
bring everyone together so that nobody has apprehensions. There are many questions which are asked that that why you are promoting it to the adult women also. Is it a commercial purposes? There is a reason why it is done for them. People should know whether you will need a booster or not, and when do you need a booster. Papilloma vaccine, papilloma virus is very widely available. Why you only girls? Why not the boys also? And what is the incentive for girls? So Britain did a very nice incentive. It got a tattoo, artificial tattoo, which you could stick on the arms, and girls were very proud to show that. And then came the influenza vaccine. This vaccine worked only between 9 years and older children. And now is coming COVID vaccine, which will be perhaps be given 5 years onward, because the trial has been completed and the results have been submitted. At the moment 12 and above, but now 5 and above will also be available. So there will be systems in with us where it will be possible to push this to 9 year and above girls, and it may not be needed to do an invasive diagnostic test. So everything is there, but the communities need to be with us to succeed. Private sector is booming. 20 crores of the doses, Gardasil and 15 of the Cervarix, are sold in the private market. This is not a government thing. And the growth of the Gardasil is around 4%, and the Cervarix is around 3% in India. So large number of girls are getting it, and then grandmothers are taking them. But these are all educated girls, educated families. The persons who really suffer are like in Africa, the countries which suffer more are Malawi and Swaziland. Most they are some of the challenged states. In India, these are in some parts of the Madhya Pradesh, in Odisha, in Chhattisgarh, in Telangana, in Andhra Pradesh, some parts of Maharashtra, Odisha. These are the states which have the most cervical cancer reported. So these are so it is really, the poorer you are, you have no control on how many children you will have and how many challenges you
Yes,
will have.
we need to all work together, I
That
think,
is where we need to concentrate.
Absolutely,
And
absolutely.
so I think my 10 minutes are up, and as usual, I talked more than I should have talked.
No,
And,
no, it's all valuable.
And
When it comes to
edit if some words were unparliamentary.
everybody is hearing you live.
Dr. Kurian is here, so edit it. Okay.
We'll have the perspective from him as well. Thank you very much for putting everything in place. That exactly all the points that we needed to touch we have touched over the past two webinars, and we are going to touch in this webinar is that how important that we talk about it. People understand and vaccinate. Vaccine works, it's safe and effective. Very simple, we know that. But we want to talk to someone, Dr. Sharmila Pimple. She has the experience of working in the slums of Mumbai, other parts of Mumbai and Maharashtra, the rural areas, particularly in Barshi. So Dr. Sharmila, thank you very much for joining. I just want to hear from you that you started long back, maybe in 2009, if I'm not wrong, when you started vaccination in the community. So what has been your experience like working with the community at that time? Can we have Dr. Sharmila Pimple, please? Rohit, can you just see if Dr. Sharmila Pimple is connected?
She's connected, but I think there is some audio issue from her end.
Okay, okay, all right.
Let me
So
just
in that,
figure. Yeah.
okay, in that case, we'll just wait for her to settle it. And in the meantime, if we can have the global perspective from Dr. Cherian Varghese. So we hear that India is not yet hasn't rolled out the vaccination in the public sector, but many countries have. So it would be a great learning for us to understand from you as to where do you see cervical cancer elimination, A, and where do you see HPV vaccination standing in the elimination plan?
Thank you. Thank you, Sutapa, and thank you for the great panel. Once Dr. Ganguly speaks, actually, there is nothing much to speak after that. So I think Sir has covered everything extensively, and I recall the good days that I used to work with Dr. Ganguly when I was at WHO India office. Now, I think a lot has been said, but globally, only about 58% of countries have now introduced HPV vaccination. That's about 112 countries, but most of them are in relatively high income settings in Europe and North America and Australia and New Zealand. The most encouraging result that I have seen is from Sweden, where girls who were vaccinated below the age of 17 years had an 88% reduction. So we now have long-term impact. So that is one very powerful thing that we have. And even girls who were above 17 years had a 53% reduction. So there is no doubt about the efficacy of the vaccine, and that programs can be scaled up. Now, for all the reasons that Dr. Ganguly has so beautifully illustrated, the woman who needs it most will never get screened, and the girl who needs it most will never get vaccinated. And that seems to be the issue. And one of the critical challenges in India will be the cost. I think $5 per vaccine, I don't think anybody will get into, because we are not a small country like Finland with 5 million population or something. Our population is so massive, and unless we reach, and as you know, the WHO coverage target for 2030 is 90%. So unless we reach that level of coverage, we are not going to make an impact. But in my view, this is the most opportune time for India to introduce HPV vaccination, because of the improvement in living standards and other changes in the determinants, the rates have come down, but the rates will go up, as we know. For example, there is a study that if England is not screening today, the rate will be about 36 per 100,000. That will be more than sub-Saharan Africa. So it is actually a myth that only some poor countries get cervical cancer. It is not. High-income countries are at a much higher risk, but they are aborting the natural history, so it doesn't end up in this thing. Now, to your some of the questions, Sutapa, I think one important issue, as we heard, is the issue about communication. And I think the three countries which experienced it big time is Japan, Denmark, and Ireland. And of that, Ireland is the one which actually reversed. Ireland had an 86% coverage of HPV vaccine. And then there was a group which actually sort of started saying about the safety issues. The coverage plummeted to 50%. So there is actually a very nice case study how Ireland overcame that. No secrets there, by creating new groups which actually vouched for the safety, bringing in girls who had vaccination, parents whose children got vaccinated. In fact, they actually used, just like in COVID, that it is WHO supported information to add credibility to that. So I think a credible information and making it sort of a social conversation should be the way to go about it. But also, I think keeping it only to the top creamy layer of the society again sort of sends some other signals. I think we need to have a more equitable distribution. So I think India should seriously think, with the kind of capacity India has, COVID vaccination is a very clear example that adult vaccination is possible. And I would even err not as a WHO staff because our guidance is two doses. I would think even if we can give one dose vaccine to Indian girls, we should just do that and do once in lifetime screening, which Usha Luthra started long back. But of course, using something like an HPV high performance test rather than VAA, which is not up to it now. So I think that is all what I need to speak to that. Crisis communication, it has to be a sustained communication, sort of echoing the same message from different parts, from teachers, from parents, from doctors, from gynecologists. I think that is something that will overcome the hesitancy as we have seen in COVID-19 also. But more than anything, the demand side should meet the supply side. If you create a lot of demand, if the supply is not there, then you actually lose it all. I think so that also has to be balanced. So thank you very much, and it has been great to have this. And I hope with all your work, India will start this. Thank you.
I'll still have a couple of questions that, one of the things that we hear is elimination. So what's the difference between elimination and eradication? That's one thing that keeps coming back.
Okay, that is very important because WHO has got different classifications. So one is eradication. Eradication means the disease is not there anymore. So that is like smallpox. Polio is going to be eradicated. Elimination is achieving a predefined threshold. So we look at globally and say what is realistically possible. So we think that about 4 per 100,000 is the elimination target. So elimination depends on a predefined agreed target globally set, to which countries can aspire. They can even go beyond. For example, I'm sure Finland will reach 3 per 100,000. They can go even beyond 4. So the target of elimination is kept as 4 per 100,000 as an achievable, realistic target. But certainly countries can go beyond that. So that is the difference between elimination and eradication. Eradication means the disease is not there anymore. But even with elimination, there will be thousands and thousands of cervical cancer. That is why even screening and vaccination is still very important.
As you mentioned that, risk communication, as we talk of, that it is important that we prepare. It's not that you just start vaccinating, you tell people that, you start vaccination. So how do you think India should prepare itself before rolling out vaccination?
I think, first of all, a very clear-cut communication strategy has to be developed. Who should say what? And then that has to be, in fact, not like the infodemic of COVID, but it has to be, now that is a very good example in front of us, how to sort of contain this sort of uncontrolled social media out there. So there has to be credible sources of information. Even Facebook worked with us, for example, for any COVID related thing. They have a small thing saying that if you want to get realistic information, go to WHO site. So I think some credibility from a national institution is one of the critical things. All states should sing the same song. I think that is so critical. Some states should not say that, okay, we are. So I think one should, I'm not speaking as an Indian, but look across seamless political ideologies and other ideologies, because that is something that a heterogeneous country can, like India, can end up with. So it is a science-based uniform communications, predefined communication materials, a standard website in multi-languages. This is what Ireland has done, actually, not in multi-languages, but a standard website which is actually regularly updated with information. And of course, Cancer Foundation and Suttapa, people like you, can really bring that together, but also percolate that down to the lowest level. I think the self-help groups are one of the most powerful women's group that could actually sort of have the groundswell on this. But at the same time, we cannot keep on preparing for a long time but then say that it is $5 per vaccine. So sorry. So I think that has to be managed there. Thanks.
And any of the learnings from COVID, you think that we can, if it's this one thing that we have learned from the COVID experience that we can put to HPV vaccination, what would that one thing be?
That massive adult vaccination is feasible. That is the kind, I think about 70 million girls are there in 9 to 14 in the age group in India every year, and I think they get added or something of that amount. If we manage to vaccinate 2 crores adults a day, I think it is possible. So the one main message is that it is possible. Second is that the entire logistics and supply chain is feasible to reach even to the remotest part of India. Third is that you can quickly change human perception on this. I think initially there was some hesitancy, but then after that people were queuing for 6 hours. So I think one should not just be stuck. Or some people said that it is not good. So it is. I think we should just overcome that and then move forward.
Fantastic. Very encouraging, I think, for us to at least think and look at other countries who have done it really well. And of course, WHO to look up to for information, as you said, consistent, because India is a diverse country with so many languages. I think many countries in one country. So I guess we all have to find our own ways of how we get it done and as a country together. Thank you very much,
Thank
sir.
you.
We'll take
Thank
a
you,
few
sir.
more questions at the end. And Dr. Sharmila Pimple, we had missed you, so we went to Dr. Varghese. So we'll come back to you to hear about your experience of working in Maharashtra and Mumbai. So the first thing is that you started vaccination long back, if I recall, around 2009. And what has been your experience that, at that point of time, how receptive were people? How did you see the community accepting it and comparing it with now that, do you think they're more receptive?
Yeah, thanks, Utapa, and hope I'm audible.
Yes, perfectly.
Yes, thank you. So the early years, India experience was mainly towards research and demonstration projects for HPV vaccination. So early years public decision making related to vaccine acceptance is by a mix of scientific, educational, socio-cultural factors. Well, local community, religious and political factors also played a very dominant role in participation. So overall, we know that vaccine evokes, concerns which are different from other health interventions like drug trials. Okay, in general, there is less risk tolerance for vaccines for healthy than that for drugs given to treat an illness. So in general, vaccine safety was clearly important and certainly the most frequently asked and addressed concern in general. So, the challenges at that point of time were not being aware about cervical cancer risk and prevention, uncertainty about risk due to vaccines. There was a perceived low risk of the disease by the women and therefore the need for the vaccines. Okay, there was a lot of skepticism being utilized as guinea pigs in an experimental vaccines because there was not much noise or communication about the HPV vaccines per se, which is still lacking. Provider confidence was important here as to who is providing the vaccines and why, the question why. And then the perceptions of business and financial motives of the vaccine industry, especially from the elite parents, and outright non-acceptance of scientific evidence for safety concern. So these were some of the challenges that we faced. But in terms of inducting and looking for participation, appropriate and relevant health education information was and still remains the key. Tackling misinformation at the basic level was crucial and very important. Now, here engagement with and listening to stakeholders, particularly parents, was a crucial exercise for participation of the minors. Information given by the physician was playing a very predominant and key role for the decision making. Okay, so the trust in the study team, okay, researchers or project managers, messengers, whether a government authority or an institute of reputation, these were all crucial aspects when we were inviting participants for vaccination. And overall then, because we were informing, giving the right kind of an health education, contribution to the health of others, larger benefit for the society, and contribution to the advancement of science, etc., was pertinent at that point of time.
Do you see anything improving now? You continue to work for the Tata Memorial Hospital.
Yeah, well, so this is very important. So HPV vaccine communications at the national level for general public and target groups is still extremely fragmented, I would say, involving certain research groups and private health platforms, since the government health communication on HPV vaccine is still missing. In general, we have to perceive that there is certain level of confidence in the government health program if they are integrated with the vaccines integrated with the expanded program of immunization for universal acceptance of HPV vaccine. This is due to the overall public trust in the national immunization program, wherein parents do not question the acceptability of the vaccines for their children, infants. Okay. So some of the Indian states have adopted the vaccine. However, inconsistencies in the program adoption and integration erodes the trust. Disagreements, I would say, at this age between various experts groups and political camps, for that matter, also disrupts the policy adoption and public confidence. We still need to bridge the wide HPV vaccine communication gap to convey the benefits for the large-scale adoption among the target population, I would say.
if we were to start vaccination communication, and we have to choose this target group, and there are lots, like, it could be adolescent, parents, policymakers, whoever. Who would you think we should start with, and how do we, put them in a sequence, and who comes first and who comes second?
Well, it will be difficult, Sitapa, to give a sequence or order. But I would say that in terms of the key target groups, okay, it involves all the stakeholders, whether it's health policy makers, government, machinery, the medical community, and the public in general. So strong, comprehensive information education from the government media communication platforms to the public is very, very crucial. Medical doctors' communication on relevance and benefit is all well proven. So government health officials reaching out to the target parent groups in public healthcare settings will be significant. Emphasis also has to be laid on primary care physicians and healthcare workers' knowledge. I stress upon the word knowledge and training about the dissemination of information on HPV vaccines is very, very crucial. Standardized messaging, what has to be, what misconceptions has to be sorted, what are the common frequently asked questions and how to address them. And then again, celebrity role model communications, both as messengers as well as survivors of the disease, is crucial. So here at this stage, I would say physician, clinic and health system based strategies need to be adopted to overcome the overall parental hesitancy for HPV vaccination if it needs to be addressed.
I think you've absolutely nailed it, and that takes us to our next speaker. That, as Dr. Sharmila says, that it is the system level, and which includes the medical practitioners, because I find that in every medical society has it in their guideline. Yet, why is it there not enough uptake of the HPV vaccination? So that takes me to Dr. Hema Divakar. Ma'am, you've been the president of FOGSI, and also someone who has been very, very active, as a leader, as a gynecologist in the country. Where do you think is the role of medical societies?
Thank you, Sutapa, and I must congratulate Sharmila for very, 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 very valid points that she has placed just a few moments ago. To me, I'll take the pick on from the communication piece, which Sharmila ji has just alluded to, because the communication, both to the supply side and the demand side, should go in a manner that it is needed. And you just see the example of COVID vaccination, how much the campaign was and how huge the communications was. Despite that, in phase 1, we said, the hesitancy is still existing, and everybody, just about everybody from lay people to everyone in the healthcare provider network, everybody started, we're doing their bit for the communication and dispelling the myths and misconception and removing the hesitancy, for example. And today we have reached such a level. So as far as HPV vaccinations are concerned, it is both the practicing doctors at all levels, okay, and somewhere in the chain, if there is a different tone and a different message that goes, then it just puts you back, because cervix is one organ which they can't even see. Many of the women, they say, have you heard of cervix? Yes, doctor, I got cervical spondylitis. That is the commonest thing that they don't know about, even the existence of cervix within their body. Uterus, okay, somewhat they will know. So that is the level. So it's such a complex and a diverse country, and the language of communication also so important. And what we did as professional organizations, initially when we tried to influence the peer group, there was a lot of plus and minus, give and take, and we really had to work our way through that. And then came a study which again put that in the back foot, and everybody else was waiting for everybody else to take on to the vaccination implementation. They said pehle aap, that kind of a situation it really became. After that, somehow the adult vaccination, when you see, Sutapa, in our community of OBGYNs, somehow the pregnancy and the Tdap or with HLS, whatever, that is where our vaccination, maybe rubella, and that's where our mind, stops with. So the adolescent, they're neither with a pediatrician nor with us. So that is another gap that I'm seeing. And now that, we start telling the pregnant mothers throughout that, soon after delivery, you can take the vaccine. That is one good target for us. Secondly, we say on the vaccination card, if it's a girl child, then at the age of 10, 11 years, we mark it and keep that this, you must give it to your daughter. So this kind of an available opportunity to disseminate and, put it in place should be taken on a war footing at every level of healthcare provision. Lastly, the cost bit is just blown out of proportion, because if you do offer the choice, it is for her, because as of now, you will see the medical community, so many unnecessary tests are asked for. So much is being done where we say cost effective when we want to say it's not cost effective. In many other modalities that we over medicalize and do, that is a serious confession that I need to make. So if they can invest that cost for, even as Dr. Varghese said, a single dose vaccine, it will go a long way. And even the Ayushman Bharat, yes, they're eligible for cancer cervix treatment, but look at the advanced stages in which they reach. Because screening, we had the opportunity 3 decades, we didn't put it in place. Now there is an opportunity to go on a war footing. We are encashing on the COVID situation because everybody has got sensitized to vaccines. Okay, then the low-hanging fruit was the COVID vaccine. The moment it came, it just got into place somehow. And we say, hey, this is another vaccine which is so important, which is so strongly evidence-based, and which is used in other parts of the world, and why can't you take it? So this is one part of it. The second part, slowly we started, a mass communication, collaborating with other stakeholders for a campaign mode to increase the demand. 10 years ago, if I would sit and tell every patient that this is a vaccine, this you must take, today I have a significant number of mothers and daughters who come and ask for it. So that shift has happened, that's somewhat. So we cannot, hopelessly say that we have not moved the needle. Somewhat we have moved, but now the availability at a better costing to have an access to just about everybody, and also the mindset of offering it as a choice, as a matter of their right to know and, utilize it. That is another. Just a small experimentation, 5 minutes of FAQ. That, do you know what is cervix? Do you know how it is spread? Do you know there is a vaccine? Do you think that you will take it if it is in this costing? Just 5 minutes when the answers are no to everyone. And they just read a picture leaflet. And then they made to answer the same questionnaire, and we published this as well. You would see a sea change. And it is not a rocket science to make them understand some little things which they ought to know, and they can really be empowered to make the decision for themselves. So a lot of these small gaps, if we plug, then it just evolves into a major movement as such. So the professional organizations, you're right, from shelves to the bedside is what we have to bring the recommendations to. They're all printed neatly. We have all accepted it should be given, but it is not got on to the last mile. So even the urban communities, okay, that significant percentage who can afford it, if you cover it, then we can slowly escalate without making an excuse that just because of the cost, that even before the patient says, we ourselves are telling, which is the wrong thing, which is quite it speaks more volumes of the provider's mindset than the patient mindset. So at every touch point of communication, if everybody is sensitized, it is not a war against. There are many practitioners who say screening, we believe vaccination next. It's not a sequence like that. And a single jab to whatever age group it's licensed for, just do it. And the point about celebrity speak also, yes, we have used that to our advantage as well, but more needs to be done. It's waiting to be done. So we had an initiative during my tenure of presidency, ABCD: A for adolescent and anemia care, B for building contraceptive choices, C for cervical cancer, kill it before it kills you, D for diabetes, don't let India be the diabetic capital, and E for emergency obstetric care. In this, believe me, all the others have moved far ahead except the C, except the cancer cervix. So I have told Ken Fraser from MSD also, sir, before this gets done, I will not die. So we have to do something about it. So that is a mass movement we want to drive. This is a country of hope. We are not giving up. We are going to revive, and so thankful to you and ASSOCHAM for having brought us together on this platform, because if we all resolve together that we will do it, and I think, things are waiting to be changing in their own merit. Yeah.
Well, I guess, we need to hear this from you so that we also get charged up, because I know Sharmila and all the others, we've been working for years on this, and we have gone through the rough of it. And in the field, all
And
of
in
us
the
are
government
familiar.
meetings, they used to shoo me off. Madam, don't come here to sell your vaccines. So at the cost of much humiliation, we have persisted in our efforts, because we know that is, probably the only way that we can get some kind of a hang or a control over this whole cervical cancer
It is
situation in the
backed
country.
by science. So it is not about selling a vaccine. It's about protecting lives, and there's science behind it. Very simple. So nothing else matters for
Absolutely.
us.
Yeah,
So
thank
I
you,
think that
Supata.
if I take a leaf from everybody else that they spoke, that, it is, it has to be consistent, of course, the message that we need to give, and we have to continuously keep on working. I have one more question, ma'am, for you now, is if it is to be taken up by a medical community, do you think it's a gynecologist or the pediatricians? Who do you think should take the lead, since it's an adolescent vaccine?
No, in fact, just about everybody, because it need not be only the specialists. Because if the communication goes right, and as we said, even primary healthcare centers, integrated health and well-being centers, preventive healthcare centers, this is all about prevention, preventing illness and promoting wellness, as the tagline of ASSOCHAM itself goes. So we have to kind of empower everybody to have enough know-how and the dissemination of communication and giving the jab out there, because it's not only in talking but walking the talk, which is important. So it is exploiting all the cadre of human resources that we have, so that the access doesn't become a huge challenge. Yeah.
Do you think FOGSI playing a role, because since it is an organization spread across the country, and it has in the guideline that, for I think from the beginning, almost since it was licensed in India, I think it was one of the frontline organizations which put it in the guidelines. So do you think FOGSI taking it up and sensitizing its own gynecologists and becoming a strong voice across the country?
In fact, FOGSI has also been, as I told you, nearly just about a little less than a decade we have been working towards this. But in the sphere of cervical cancer, neither the screening nor early detection and an organized registry, and to see the coverage of the vaccines, it has not happened in as systematic way that we would have liked it to unfold. So there are huge gaps, not some little gaps, huge gaps, but it's easily doable. And on every forum, we are sensitizing more and more. But the numbers, Sutapa, are, of the convinced community who are actually proactively making an effort to speak about this and get this out there, is happening, in a greater scale than ever before. That much I can definitely say. We just, it's a question of a little more time, when the demand also raises, and then definitely the providers will have to comply with that, and we tie up both together and just move the needle.
Fantastic. So that brings us to the provider here, the most important stakeholder in all this, that we are talking science here, because see, in HPV vaccination, the game changer is going to be when every girl in the country gets it for free. I think that all of us would be happiest when the government takes it up and includes in the UIP, the Universal Immunization Program. But what is going to be important is, do we have enough vaccines? So the most important person, as I said, Dr. Rohit Gatule is with us, and they have worked the longest because they manufacture the vaccine, one of the companies in India that manufactures the vaccine and provides to us. How do you think the community has taken, Dr. Gatule, in the experience of dealing with the vaccine for years now?
Thank you so much, Sutapa. Hope you hear me well, right?
Yes.
Yeah, okay. So thanks to ASSOCHAM as well. I think this is a pertinent question which everyone has, and I think most of our speakers have spoken about some way that how community has kind of taken up the vaccination and specifically Dr. Pimple kind of also kind of outlined certain aspects about of the community's feedback about it. But what we have seen is I think over the years now we have been seeing that this is very encouraging and enriching journey so far for MSD and Merck & Co globally also. As Dr. Varghese mentioned that we
You
have
are
more
not
than 100
audible,
countries.
Dr. Bhartu. Your voice is a
Just
little
increase the,
low.
yes. Dr. Rohit, if you can just increase the volume in any way, or is there any other
Sure.
setting?
Okay.
It's
So can you hear me
better.
well? This is better?
Better, absolutely.
Okay.
Please go ahead.
Okay.
Sorry.
As I was mentioning that Dr. Varghese mentioned about the number of countries which have adopted the vaccination and the UIP program. I think that's the far more the best program to have it, right? What we've seen in kind of some examples which are within Asia Pacific region itself. Bhutan is one of the critical examples. Our neighbors have adopted more than 90% of vaccination in the target population. Similarly, Australia. So there is kind of a great level of attraction and adoption by the target population when educated very well. In India specifically, we also seeing this same level of successes in certain states. We have been working with certain states in Sikkim, as Dr. Ganguly was mentioning about in the beginning, Punjab, some work in Telangana. I think we've been supporting their endeavors, and the work there has been very enriching, and adoption has been very well there. And Sikkim specifically showcases that the adoption and the acceptance can be strong. Punjab, at the other end, we saw that has included HPV into their own immunization program within the state level. So I think in federal way we are adopting. I think, but as Dr. Divakar mentioned, right, all forces need to join together to at the country level to work in a very stronger way. Just to kind of again reiterate certain facts that though 100 plus countries globally have adopted, LMIC countries, the adoption rates have been on lower side, and that's why we could see that disparity in also seeing cervical cancers more prevalent in our countries and lesser immunized countries, and India specifically accounts for more than 1/5 of the global cancer burden. So I think at one end we are seeing good adoption by certain states, but I think a great level of movement has to happen at multiple stakeholder level, starting with not only kind of the group we're talking together now, but I think at grassroots levels like education to general public, and I think no better an opportune time now to showcase the importance of vaccine. And I think, as quote says, right, as we choose hope, anything is possible. So I think let's choose hope for now, and I think I'll give it back to you, Sutapa.
And do you have like any plans as a manufacturer of developing any communication program? Because it has to be large scale again, the kind of country it is, and we've seen in COVID times that the messages were all over across every platform, virtual, print, everywhere. Everybody was talking about the message. So do you think that you could plan something as big in the coming years, if not now?
Yeah, I think that's a very difficult answer to say. As an MSD alone, I think I would say that we can do a bit, right? It would be a drop in the ocean. But I think there are certain programs. I would say very strong programs coming from our side. There are programs for consumers, specifically programs for the healthcare community itself, and also program to kind of collaborate with the government stakeholders itself. So I think there are three different levels of programs which we are trying to target from our own side. We have some great experiences from global, some kind of certain programs which we have seen at the global level, which have been very successful, and specifically the school-based programs, I think are the best programs which we have seen to kind of attract and disseminate the right knowledge to the right target population, where both parents as well as the school administrators are there who kind of note the importance of such a vaccination. We kind specifically targeting such a population which is kind of outside the immunization scope, right? As Dr. Divakar mentioned, this is not there in the list of normal immunization. And adolescent group of population is usually neither fitting into a pediatric group and neither fitting in a group which is vaccinators. Like only females would go to a gynecologist and they could be given vaccination. But now we are entering into an era of gender neutral vaccination where both boys and girls both are vaccinated together. So I think from our side, from MSD's perspective, I think from consumer piece, I think we'll be working strongly towards having strong social media presence. Social media, specifically the target population where it is working, like Facebook, Instagram, other social media platforms like Twitter, also would be kind of our forte where we would try and kind of attract the target audience, particularly teenagers, young adults, for improving their health. And now we have seen. I think some of the speakers rightly mentioned that the attraction for the vaccination is such huge that now people are queuing up for 6 hours altogether to get a COVID vaccine. I think more so the importance of health has been kind of determined now that how health is so important for us and integral for us, right? So I think that will be the first piece of working together from the social media platforms. And I think we've seen that these have been very strong platforms to kind of encourage everyone to kind of own their own health. For example, one of the programs which was run in Singapore, specifically the program's name was It's Your Life. And it was specifically targeted towards Singaporean men rather than the females itself. So where it was kind of the target population was completely different altogether as compared to what we would have thought of, right? And it gave a kind of a sense of kind of responsibility towards that. Yeah, we should be vaccinating, and it is also a vaccine which was required for men also, and specifically the adolescent boys who could be kind of future saviors of transmitting such a virus altogether. The second piece which I was trying to talk about was educating the doctor community itself, right? As Dr. Divakar highlighted, right? One of the being a non-direct to consumer market, and ours is one of the challenges, right? Pharma cannot talk to the patients itself, right? Directly, and it is seen as a wrongful promotion, and that's why probably we usually kind of defer from doing that, and there is also a sense of kind of deferment from doing that directly from pharma. But what happens is, for us, the primary level of increase in awareness is for the pediatricians, the gynecologists, but we can reach through that much only, right? We have that many arms and legs only whom we can reach out to. But I think the third level piece which comes in here is the government mobilization, the strong political will needs to be kind of honed through, probably which we are doing through various efforts which our public affairs team is doing, and probably Sutapa, from your efforts, what you're doing, Dr. Ganguly, who has done fantastic work, Dr. Pimples, who has done fantastic work. I think this is how probably we will be driving furtherance of importance of such a vaccine through the government stakeholders. And once I think this is in the UIP program or the universal immunization program, I'm sure that this will become a pen habit for everyone to take care of. So I think these are the three areas which we will try and work for. And there are numerous examples globally, but I think I'll stop here in case if there is some interest in the global programs, we'll try and touch base upon the global programs as well.
I think it's very encouraging. All the speakers, I think, have come to a point where we need to talk about it, I think, at different levels. So I have a few questions from the audience, which I want to just take up. First to Dr. Varghese. We heard that there are a lot of global programs that have worked in the Southeast Asia region, globally. You've seen countries which have rolled out, countries we have planned. So which are the countries you think India could learn? You know, the programs that they have conducted, any of the LMICs you think that we can focus on?
I think most of the countries which have introduced as a nationwide introduction is in high income countries, but it is happening in Thailand. Thailand is a good example that India can look at. We also have to look at the size and complexity of India, which is not something that we can learn from others. I think we have to sort of learn ourselves how to do this as we did the COVID-19 vaccination. but it is rest assured that countries have more than 10 years follow up on real cohorts, and then real data is out there, not just estimations of the impact. So I think India can be fully reassured of the 112 countries or so which have introduced, and that it is safe and effective. It's only a question of how we can afford that, given the very high price of vaccine, which I think is beyond the reach of most countries of the world.
And the WHO is provides technical assistance to the states which rolls out the vaccination in India. So what is it that entails, that technical assistance package, when they're rolling out?
No, WHO sort of brings in the evidence and evaluation that has been carried out. It helps in sort of creating the messages, answering some of the technical issues which are always raised. Should we vaccinate boys and girls? Of course, if you can have enough money and enough vaccine, certainly. But then as a priority, we start vaccinating in girls. Should we vaccinate everyone, or should we at a particular time period? Again, as we can say that, look, below the age of 17, like the global strategy says, by 9 to 14, if we vaccinate, we have the maximum impact. So WHO provides that level of guidance on optimizing, because we have to get the best out of the minimum money that we have, and then in communication, and then adds the credibility on a neutral platform. Because if you look at most of the other entities, the challenge is that there is always some sort of influence likely out there. So WHO can then stand on a neutral platform and then just look at this thing. So the WHO immunization group has put together an HPV clearinghouse, and the HPV clearinghouse, I can post it in the link. The link can be posted there. People can get information on various aspects of HPV.
Because I think many of the states, even if they are able to manage the financial resource, sometimes what actually stops them is the technical assistance. They do not know how to roll out in a larger population, because there are a lot of information that they get, but structurally, I think WHO would be a great help, which I think they have provided to Sikkim. I think Sikkim, Punjab, all the states, WHO has been the technical support to them in rollout. Thank you very much, sir. Having said that, if we are thinking of rolling it out, it has to be part of the universal immunization program. It's only when every girl is protected, we will be solving the problem. It's not, one or two individuals purchasing it. So I'll take it to Dr. Ganguly very briefly as to, when do you think, or how do you think India should plan to include HPV vaccination in the UIP? What do you think would be our strategies? How do we take it up? Your suggestions and your ideas, so that, we all can.
Two suggestions.
Yes.
One was the two revealing facts that how many ladies are dying because of the cancer which are diagnosed as cervical cancer. All are coming very, very late. So with the vaccination, we should also bring in awareness as well as all public health measures, which will actually Sharmila is there, but Tata Memorial Center's policy is not vaccination, but public health measures, which is more cost. It is the director's view, not Sharmila's view, but director's view. I know it because I'm in their board for about 2 decades. So that is their policy. So public health, like you cannot control cholera and say that don't provide clean water or wash. So the wash here is also important. Public health measures is important, along with the vaccination drive, and also point it out that who are dying and why so many ladies are dying who are diagnosed as cancer, because they're coming late. Second thing which I will suggest, that link it to the overall women's cancer movement, breast cancer, cervical cancer, because women's cancer is at the moment more gender sensitive, and it moves much more easier, and women have hesitancy to really go to a surgeon for breast cancer examination, or go to a male gynecologist for the cervical cancer things. So if we have a women's cancer program, which is normally community based. Our cancer program should spread to community. We will be doing much better. My third measure, which I will like to say, that what Dr. Diwakar said about that most ladies don't know what is cervix. This is horrendous. If my mother knew how much wrong information I had about sex or reproductive organs when I was in my school, she will be horrified. But that is what we learn at the school. So the sex education should start from. There will be a lot of opponents for this, but because India is a very pure country, spiritual country, but during HIV we learned, during this time we have learned that sex education is an essential part right from the beginning for the people to really understand their body, and then that is how they will do. The third is the communication, and fourth is the communication. The way we communicate with the people, they don't understand our language. When I was working with the Musaharts in Bihar, Nepal, and Bangladesh, these are rat catchers. They don't have a home, they don't have a TV, they don't have newspaper, they don't have even a telephone. And they are the main sufferer from the disease which I was looking at. That was a disease of poverty. There is also a disease of poverty. So we need to really link it with the diseases of poverty. And we also need to communicate well. In these circumstances, there are other methods of communication, the language which the target will understand. And here, the major thing, one of the programs which I carried out with Andre Quadros, a music teacher for Boston University in Ahmedabad and Pondicherry, we really had tremendous health benefits when we used music, street plays, flash mobs, things like that. The people understood what we are talking. They should know who are the providers. When we were training in Aragonda, that do basic in the primary health center, basic examinations, they didn't know. They need them. There need to be a massive training program for class 10, class 8 girls or nurses. These will be so. Our communication is wrong. We need to link. You cannot separate child and mother. The mother and child need to go together. When you have a bad reproductive hygiene, you not only have a papilloma virus, you have rickettsia, you have chlamydia, you have vaginosis, every kind of. About 70% of Bang's paper has shown about 60 to 70% of the ladies in rural India have white discharge. So if you could really, and the bad outcome, child outcome. So many programs now include erythromycin to the pregnant ladies, or there are other interventions of having a good reproductive health with a good reproductive pH, so that you could really get an overall outcome. So don't separate child with mother. Go together. That if you can do, if this message is given, that if you have a good reproductive health, if you take a vaccination, your child will be healthy. Your child will have a linear growth.
Mhm.
So, and also propagate the peril of substance abuse. When I was working in field, how many ladies are taking oral tobacco in rural settings, in 270 villages of Kanpur Dehat, about 30% of the ladies were taking oral tobacco, and that tobacco is found in the reproductive tract of the ladies. So you have to really link up many things together, make it a holistic approach, and talk a language to the government, to the communities, and using community elders, create a pressure group like the thalassemia group and hemophilia groups have created through the cervical cancer survivor mothers. They will be the best messengers. Create a large group, pressure group over here. Create a group of parliamentarians as we did in the HIV. First Kapil Sibal, then the Prime Minister of India. So these are some of the things. We need to create a community voice. A community should demand what they want. They should see the benefit of what they are really asking for. Only then the political system will respond, and they will then you will get what. And two Indian companies have come up with the HPV vaccine. Third one is on its way. So soon the prices will drop appreciably. At the moment, private market prices are more than 3,000 rupees. So the prices are likely to drop when two Indian companies, they have got, the Zydus Cadila has got, Serum Institute has got. So there will be Indian HPV vaccines. And the third one is coming up. So I'm not at liberty to tell you which is the third one, but it is coming up. So this is the approach we should have. Overall holistic.
Yeah, that I think is wonderful, because that puts it in perspective. What is it that we need to do next? So, for us to plan well, keep it to scale, of course, and making sure that we make
and we need more Sutapas. Why there is only one NGO
Dr. Ganguly's
in
also.
Calcutta
For
fighting?
flash mob, I was actually excited to hear that you're so updated, that you know flash mobs as well, which is exciting. So we need more like you as well, because you need to encourage us and give us more ideas. That's wonderful. I come to the last bit of it from all the speakers. As Dr. Ganguly said, I'll take it to Dr. Sharmila first. What is the one thing that, if you were given a choice, would you take up for engaging the community? That one thing that you think is the priority?
Well, Sutapa, it's very difficult to address it, as one thing. The way COVID vaccines in general and the role of new age media in particular, the way the COVID vaccine science has played out in the public and media domain will be a definite game changer and will impact how people are going to participate in future vaccine program. So the data is for the government, like SARS-CoV-2, we have the HPV vaccine proven efficacy of more than 95% of the HPV 9 people. Such robust evidence-based scientific data can be now leveraged for bridging the vaccine confidence gap and vaccine uptake and coverage. So we need to address the low perceived need of risk for sections of the population, I would say, and branding the disease primarily as an STD has been one of our biggest messages from the communities that we have adopted, and we should be avoiding this kind of a reference in terms of it being a sexually transmitted disease and women segregating themselves from that. We do not belong to that category of people. So we have to be particular about the kind of messaging that we are doing, and the benefits of the vaccines has to be rolled out more than trying to give the perception about who are at risk. I think that's a primary message we have taken from our communities, which has impacted and created a barrier, and we are trying to resolve our education messages, which need to be very, very precise, crisp, and just for the benefit of the community. Thank you.
Wonderful. Dr. Devakar, your one thing that you think the medical societies can do?
Take the jab is our message. Just go for it. So we have to make that happen, and not continue to be talking about it. And therefore I feel, taking the clue from what the COVID scenario has showcased to us, all the medical community, now we are all aware that the guidelines are there, and if people come to us, we will give. That's a given. Now we don't have to too much invest our time and in convincing our community that I'm convinced. So how to make people come? So just like in COVID, we say, okay, have you taken the jab? And all the employers, in their tech companies and wherever, and also there are a lot of these construction workers, everybody got their vaccines through somebody. So if the same ripple effect can happen and that mechanisms can work and we have larger population being covered, that itself will give out a signal, and we can amplify our voices through professional organizations, both at the national and international level, FIGO, and tell the government, look here, please, we really need this. So we have to make this happen one way or the other. So I think, again, once again, I place on record my humble thanks for this forum, because it has even inspired us to, why are we not doing what we can do, and we should. So I think we should move ahead. Yeah.
Thank you, ma'am. And Dr. Rohit, you hear that everybody's excited. So are you equally excited as the manufacturer?
Absolutely. I'm part of the kind of entire group, which is I'm not the manufacturer itself. But I think super excited. I think the comments by all of the panelists have been very encouraging, and I think there's no one thing for sure, Sutapa, we can do. But I think it's one person each. I think that's one thing we can own, at least from our side. We do the commitment that we will provide all the logistics and all the vaccines which we can provide from our side. We'll try and engage with the community, which is best we can do from our side. But I think if I have to kind of still ask which is the one thing which I would say, I think it would be a strong political will to kind of include it into the UIP program. I think that would kind of move the needle the strongest if we do that change. And I think education is a matter of time. I think in the digital world, everyone is educating themselves more so than we kind of realize the fact that we are educating them. But I think everyone is trying to educate themselves and taking their own decisions. So I think we'll leave it there for everyone to decide. But I think we can only do is educate.
Thank you. Wonderful. Dr. Varghese, I want the last statement from you before I give it to Dr. Kocher. Dr. Varghese, that one thing you think we should prioritize as community level organizations working, what is it that we should focus on first?
I think credible, unambiguous messaging is something very important to make sure that we don't propagate different ideas. So I think consistent, credible, unambiguous, science-based, standardized messaging has to sort of reverberate across civil society organizations. And other measures have already been said. And I also think that there is no escape but to reduce the price of vaccine, because I think there is no way with all the political advocacy we can do, but with the kind of pricing that we have, it is very unlikely that governments will put it under UIP. So just that also. Thank you.
Let's hope that the price comes down sometime. As Dr. Ganguly said, more and more manufacturers are coming in. So with the Indian ones coming up, I hope the price comes down. So there's a lot of positive vibe here. We can see things happening. It might take a little time, but possible. There are a lot of questions on the chat box, which I could not take. So that means that we have a lot many more questions raised. There should be more discussions at some point. So we would request ASSOCHAM to consider more discussions, creating platforms for this. And we would like to thank ASSOCHAM for this 3-webinar series. And over to Dr. Kocher. Ma'am, you have to unmute yourself.
Thank you. It's really been wonderful, in fact, listening to all of you. And Sutapa, you've been really wonderful, conducting this whole thing. And I've learned so much, because the reason being is that when I really, I had a number of friends, in fact, about three to four friends who all died of this cervical cancer. And it was such a quiet cancer, actually. And this is what I keep telling people. It is so silent. You don't even know you have the cancer till it's really so late. And that's what I was listening about. And then they go and take it. And then after that, when I kept telling all my friends, the other friends, and everyone I used to lecture to, the students, I used to tell them, take this vaccine. but somehow really it never used to get into the heads, never even got into the mothers' heads to take this vaccine. And I'm really so glad and so thankful for all of you for having this and bringing this out, because this is I was hearing, like the breast cancer, this should definitely be treated like a cervical cancer, and it should be clubbed together. It is going to do so much of good. And I'm sure the prices and everything is going to come down. And I think we need to have more of these kind of, talks so that it could go through. And I would really like to take this opportunity to thank our esteemed panelists who shared their views with us and helped us to carry out the series in a successful manner. Also for taking out their precious time and giving insights on the very important topic, which is a need of our hour. On behalf of ASSOCHAM, I am also thankful to Cancer Foundation of India and MSD for supporting this very meaningful live web series. And I really would love to have more web series like this. So because I think this is what's really going to spread it, and we need to definitely spread it. HPV vaccination provides an opportunity to reduce multiple HPV-related cancers, therefore increasing uptake of the vaccine among youth of both sexes is a vital public health issue. Public awareness and national immunization programs are the tools to reduce HPV infections. So it's time to end cervical cancer. Get vaccinated, get screened. I once again thank all for taking out your time and joining us for this very important discussion. Thank you. Thank you so much.
Thank you so much.
Thank you.
Good night.
Thank you very much. Really
Thank you
enjoyed
so much.
Sutapa's
Thank you.
moderation as well. Thank you.
Thank you.
Bye,
Thank you.
everyone.
Bye to everyone.
Thank you. Bye bye.
More
Nice
action now.
meeting all of you.
Yeah,
Thank you.
great action. Great action.
Thank you.
Thank you, everyone. Thank to ASSOCHAM and thanks to Sutapa.